Hi everyone, welcome back to UWorld's Next Gen NCLEX Review. My name is Samantha. I am a nurse here at UWorld. Thank you so much for tuning in today. So today we have a pretty big topic at hand. We're going to be covering our acid-base imbalances with our ABGs, or arterial blood gases. So pretty tricky stuff, but we're going to go through it slowly and we're going to get through it together. So we're going to cover metabolic side. We're going to do acidosis and alkalosis before we move on to the respiratory side with respiratory acidosis and alkalosis. We're going to include all that good stuff like our causes, our clinical features, and our nursing interventions. So we have a couple of questions sprinkled throughout just to test your knowledge, make sure everyone's doing okay, staying along, and then we'll of course have our typical NCLEX style questions at the end. Today we have an extra special bonus third question, so make sure you stick along and tune in for those at the very end. A couple of housekeeping things before we get started. Follow us at UWorld Nursing for more information on all of our live sessions and our social media so you don't miss any of our content in the future. Visit uworldnursing.com for our complete schedule with times, topics, and channels that we're going to go live on and about. And let us know in the comments if you've already tested so we can congratulate you, or if you're about to test so we can wish you good luck. We have Nurse Jackie moderating for us today. So as always, drop your comments, drop your questions into the chat so we can answer those or say hi, and of course drop your answers to any of the questions we ask throughout today's lecture into the chat. So with that being said, let's go ahead and get started. So let's start at the very basis. So acid-base imbalances are going to be a complication of a condition. They're not a standalone diagnosis by itself. So the acid-base imbalance are going to be going on in the background essentially when something else major is at play to cause it. So these imbalances are typically going to be focused on dysfunction in one of two areas. So when we have metabolic imbalances, being metabolic acidosis or metabolic alkalosis, we're going to have kidney problems. And when we have respiratory imbalances, being respiratory acidosis or respiratory alkalosis, we're going to have lung problems or breathing problems. So to understand when we're out of range with our values, we need to understand what our reference ranges are. That way we can spot these imbalances when they do arise. So we're going to talk about three things in particular. First is that pH. This is going to tell us, is our blood acidic, is it normal, or is it alkalotic? So I'm going to ask you guys a question. What is the normal pH range? Go ahead and give me a value, and if you only can get one, no worries, but drop that in the chat, let us know. Again, what's a normal pH range? Testing your knowledge. And right off the bat, I see Shanice got it, and Nell 7.35 to 7.45. You guys are totally correct. Hope, Mitch got it, Dell got it, Laura got it. Way to go, you guys. Great job. So yes, our normal pH is between 7.35 and 7.45. A number below that 7.35 would be indicative of acidosis, and a number higher than 7.45 would be indicative of alkalosis. So on the low side, we're acidotic. On the high side, we're alkalotic. Our next number is CO2. So we've learned about carbon dioxide a couple of times through our live. We hit this point really hard in our COPD live, but high levels of carbon dioxide are going to make us acidic or have a low pH, because that's the acidotic side. A normal range for carbon dioxide is going to be 35 to 45 millimeters Hague. A great way to remember this is take that normal pH, 7.35 to 7.45, and just drop the 7, and that gives you 35 to 45, which is a great way to remember carbon dioxide levels. Our last point to drive home is our base, our bicarb, that HCO3. So a normal bicarb range is going to be 21 to 28 mil equivalents per liter. High levels of bicarbonate, that's more base, they're going to make us more alkaline or be in a state of alkalosis. So again, pH, carbon dioxide, and our bicarb are our three most important values to know. The good news is that the NCLEX now gives you our normal reference ranges, so there's less memorization work on y'all's side. So a little bit about the general principles about these imbalances before we dive in. So acidosis, again, too much acid or a loss of too much bicarb, and alkalosis is too much bicarb or base and a loss of too much acid. So With that in mind, let's dive into the metabolic side. So what are some causes of metabolic acidosis? We're going to switch to our acidosis scale to give you a good visual to go along with this. Again, anything that we put up there, you guys are free to screenshot, take with you. So let's start with metabolic acidosis. So again, we know metabolic means kidneys. Our kidneys are impacted. They're the, problem players here, and acidosis means we either have too much acid, making us acidotic, or we've lost too much bicarb or base, putting us into a state of acidosis. So reasons for too much acid can either be from too much acid production, like an increase in lactic acid. We can see this in our circulation from poor perfusion, or even in cases of carbon monoxide poisoning, or we can also see acidosis from the release of ketones, as in DKA or diabetic ketoacidosis. It can also be as simple as intaking too much acid, like taking too much aspirin, which we know is acetylsalicylic acid. Excuse me. We can also see metabolic acidosis from the impaired excretion of acid. So we're not able to get it off. This can happen in kidney diseases. We just did a live on chronic kidney disease. Check that out if you want more references. Remember, our kidneys are ultimately what decides what's going to be filtered out through the urine and what we're going to hang on to and send back into our blood. So if the kidneys aren't working, or if they get backed up, we're going to have a buildup of waste and electrolytes in our blood, including a lot of these really acidic elements, putting us into a state of acidosis. Our last cause of metabolic acidosis are going to be anything that causes us to lose too much base or lose too much bicarb. So problems with excretion, and this can be like excessive diarrhea when we're losing that bicarb, losing that base, putting us into a higher acidotic state. This can be like diarrhea from C. diff or gastritis or something like that. Alrighty, so switching sides, we're going to stay in the metabolic side, but let's think about alkalosis. So we're going to pull up our alkalosis scale. And again, what are our causes of metabolic alkalosis? So we're switching gears now. We're thinking on the opposite side of the spectrum. It's the same principles as metabolic acidosis, but here we're going to just reverse it. So we know metabolic means, again, our kidneys are affected, and alkalosis means we have too much bicarb, i.e. base, or we've lost too much acid. Reasons for too much bicarb can be as simple as excessive ingestion of bicarbonate, like taking too many antacids. This is pretty much just like straight bicarb tablets, so this can be a cause. These are like Tums, for example. Or we can see large amounts of acid loss put us into metabolic alkalosis. So think about our stomach when we think about too much acid loss. Our stomach is full of acid, so when we have excessive vomiting, or maybe we have excessive suctioning, they're set up to suction via an NG tube. Anything that's consistently pulling acid out of our stomach is going to remove that acid, causing us to be too alkaline. So in the same vein, also think about medications like diuretics and thiazides. So it can cause the excretion of hydrogen in our urine. We know hydrogen is acidic. It's a driver for pH. After all, pH stands for potential of hydrogen. So when we're losing this hydrogen, we're losing our acid, and our pH is getting higher, i.e. more alkaline. Alrighty, so that was a lot. Maybe take a second and we'll take a deep breath, but you guys are doing great so far. So now let's go back to that acid-base table. We're going to look at some clinical features here. So clinical features of metabolic acidosis. Essentially, what does this look like in a clinical setting? What are these clients going to present with? We need to think about things that will cause metabolic acidosis. Let's think back to DKA, or diabetic ketoacidosis. So these clients often present with something called Kussmaul respirations, those really deep, really rapid respirations. They also may have signs of hyperkalemia, which we know we can see cardiac complications from this, like dysrhythmias such as peak T waves. And we also know that diarrhea can be a cause of this, so we can see diarrhea in these clients. Our clinical features of metabolic alkalosis on the flip side, there isn't a whole lot to say about this, but again, it's when we're getting rid of all that stomach acid, clients set up to excessive NG tube suction, or who are vomiting too much, are getting off too much acid, they're going to have metabolic alkalosis, and in general, this client is going to feel very unwell. So now we're going to jump into compensation, and this is kind of where things get nitty-gritty. So if you need to take a little stretch, take a little breath, let's do that. But we know what's going wrong. We know our clinical features. Now, how does the body compensate for this? How do they make up for it? So let's talk about metabolic acidosis first. So we're on that low pH side, that acidotic side. And remember, metabolic means kidneys. So remember, we have that low pH and we have that low bicarb. So in response, the lungs are going to kick in to help out their friends, the kidneys. The kidneys are not really working to full capacity here, so our friend, the lungs, need to jump in and help. In response, the lungs are going to increase their rate of breathing, so we have an increased respiratory rate, so the lungs can blow off more of that CO2, which we know is acidic. So when we're blowing off that CO2, our pH is going to rise because we're getting rid of acid, making us more alkaline. So our lungs help by blowing off that CO2. They increase the respiration rate. We may even be hyperventilating here. Now, compensation for metabolic alkalosis, let's think of everything in reverse. It's the opposite. Here we have a high pH and low acid. We are more alkaline here. So in response, the lungs are going to slow down to help those kidneys out. We're going to see a decreased respiratory rate because we're holding on to that CO2 because it's acidic, bringing our pH down back to a normal range out of a state of alkalosis. This is going to help lower our pH, and our bicarb will lower as well. Alrighty, so quick knowledge check. Just make sure everyone is staying up to date. So knowledge check, will breathing increase or decrease in metabolic acidosis? So a client in metabolic acidosis, will the lungs compensate by increasing their rate of breathing or decreasing their rate of breathing? You have a 50-50 shot of getting this one right. All right. Take a second, mull it over, think about it, but metabolic acidosis, are those lungs increasing the rate of breathing or decreasing the rate of breathing? And a big hint here is think about what they're breathing out, what they're getting rid of. What do we have too much of in metabolic acidosis? Alrighty, I see a couple answers coming in, and we may be a little bit torn here, but we are increasing our rate of breathing in metabolic acidosis as a compensatory mechanism to breathe off excess CO2, meaning we're going to increase our pH, taking us out of acidosis, hopefully into that normal range of 7.35 to 7.45. So increasing was our correct option. Way to go, you guys. Looks like a lot of you got that correct, but that was a really tricky one. So no worries if you're still a little bit confused. Let's go over our nursing interventions, and this may really help to drive this point home. So remember, metabolic acidosis and metabolic alkalosis are never the primary diagnosis, but rather a symptom of another condition. So obviously, nursing interventions, the first and foremost thing we should do is treat the underlying cause. But there are also some additional supportive measures that we should know to take as nurses. So in general, we need to make sure we're monitoring our ABGs, we're administering IV fluids, and giving electrolyte replacement as needed. For metabolic acidosis specifically, we need to monitor our lab values, especially that lactic acid. We know we have elevated lactic acid in sepsis, so we definitely need to watch how this is trending. And again, it's an acid, so it's going to continue to make us more acidotic. We also need to replace fluids and electrolytes as needed and give certain medications. So we know that diarrhea can cause metabolic acidosis because we're getting rid of all that bicarb in the stool, so we may need to give an anti-diarrheal like a Lamodal, and we may even need to give some IV bicarb to the client to help get them more alkaline and out of a state of acidosis. On the flip side, for metabolic alkalosis, it's the same basic principles, just in reverse. So we're, of course, treating the underlying condition. We are replacing fluids and electrolytes as needed, and we're going to give necessary medication. So big cause of metabolic alkalosis is vomiting. So we may give an antiemetic like azofran, Phenergan. We also want to make sure we're stopping the use of diuretics so that our kidneys start sending that acidic hydrogen back into our blood instead of excreting it through the urine. So we're stopping our diuretics because we want to stop the loss of that hydrogen. It's acidic and we can hold on to it to take us out of a state of metabolic alkalosis. And we also want to make sure we're avoiding suctioning. Again, suctioning is going to remove the acid in our stomach if it's like set up to an NG tube. When we remove the acid from our stomach, it makes us more alkaline because we're getting rid of acid. So we would want to stop this suction. Alrighty, that was a lot, but you guys did so great. Way to go. I see a lot of people interacting in the chat, so happy to have you all here. If you are just joining, we're going to do a quick summary on the metabolic acidosis and alkalosis that we just did. We're going to jump to our flow chart as a little refresher before we move on to the respiratory side. So again, metabolic acidosis, let's pull up our cute little flow chart, and this is going to be a great visual for you all. Metabolic acidosis means low pH, so we have too much acid and not enough bicarb. Our kidneys first try to compensate themselves, but when they can't quite cut it, they're going to call in backup from their friend, the lungs. The lungs are going to breathe faster to blow off that excess CO2, which is an acid. When the pH returns to normal, then we will be considered fully compensated, but we will have a low CO2 because we blew it all off, which means we're going to end up in something called secondary respiratory alkalosis. Kind of confusing, but you see how this is such a tender balance. It can flip from one side to the other relatively quickly. On the other side, we have metabolic alkalosis. Here we have a high pH. What happens here is we have low hydrogen or low acid and too much bicarb. Our kidneys first try to compensate, but when they can't cut it, they're going to call in for backup from our lungs. Our lungs are going to breathe slower to help retain and hold on to that CO2, which is an acid, and by holding on to that, we're going to see our pH decrease, go back down towards a more acidic side, hopefully return to normal. When the pH is normal, we would consider this to be compensated, but we're still going to have a higher CO2 because we're retaining it, and this is going to put us into something called secondary respiratory acidosis. So you see how the compensatory mechanisms can sometimes go too far in either direction. Alrighty, so that was a lot of information, but you guys are crushing it so far. So let's go ahead and move on to the respiratory side. So we just covered metabolic, which means our kidneys are, having a little trouble. Now let's switch to our respiratory side. All right, we're going to pull up our acid-base table again. All right, and we've talked about respiratory drive a lot on our COPD live session. But just a quick refresher, if you want more explanation, go ahead and check that out on our YouTube page. But remember, we breathe in oxygen. I think we all know that at this point. This oxygen makes its way through our upper and our lower respiratory system, where that gas exchange eventually happens in the alveoli of our lungs. So our blood here at the alveoli is going to offload that CO2, and it's going to pick up some fresh oxygen at the alveoli. The CO2 is really where all of this imbalance starts in the blood. So in respiratory acidosis, we're going to think about hypoventilating, breathing slowly, and this is going to cause a buildup of that CO2, which is acidic, and it makes our blood more acidic, putting us into a state of acidosis, which means we have a lower pH. On the other hand, in respiratory alkalosis, here these clients are typically hyperventilating. They're breathing too fast. They're blowing off all that acidic CO2. Therefore, they're getting rid of too much acid, which is going to increase our pH level to a more alkalotic state due to that lack of acid. So quick refresher here for respiratory. We are hypoventilating, means we're going to be put into respiratory acidosis. If we're hyperventilating, we're more likely to be in respiratory alkalosis. So let's go over some causes here. What are some causes of respiratory acidosis? So let's talk about this. We just need to really tie everything in to that hypoventilation that we just brushed on. Let's start with some acute causes. So first, our client can have an airway obstruction, super scary. So along the lines of choking or aspiration, they're hypoventilating because they're not able to breathe. We can also see chemical respiratory depression, so anything along the lines of an opioid overdose, maybe alcohol intoxication, even magnesium toxicity can cause respiratory depression. And lastly, it would be respiratory muscle weakness. So we can tie this into the pathology of like Guillain-Barré syndrome or a spinal cord injury. Remember that the part of our brain that controls our breathing is in the brainstem. So injury to the cervical spine area can really impact our breathing centers and what control that. Those are the acute causes. So the chronic side that cause respiratory acidosis, things here are going to be like COPD, that chronic obstructive pulmonary disease. We talked a lot about how clients who have COPD, their respiratory drive is triggered by oxygen instead of CO2, which would be normal. So the body essentially becomes accustomed to these rising levels of CO2, and it blunts the respiratory system response. So again, we have our acute causes of like airway obstruction, chemical respiratory depression, any kind of respiratory muscle weakness, and then we have our chronic conditions being COPD. Alrighty, so flipping the script, other side of the mountain here, what are some causes of respiratory alkalosis? So moving on to alkalosis, we remember that respiratory alkalosis, these clients are going to be hyperventilating. They're breathing too fast, breathing off too much CO2, getting rid of too much acid, meaning they're going to be alkalotic. So let's talk about things that cause hyperventilating. Panic attacks and anxiety attacks, as well as some pulmonary conditions. Like think about pneumonia, maybe an asthma attack, things like a pulmonary embolism or a PE. All of these things cause impaired gas exchange, either from obstruction in the airway or lungs or problem breathing. Other causes can include things like fever, high altitudes, and a client on mechanical ventilation who's on improper ventilator settings. Alrighty, so I see pain as another example. Great job, you totally nailed it. So clinical features, what are we going to see these clients in a clinical setting? What do they present with? What do they look like? So let's start again with respiratory acidosis. What do these clients look like? So beyond just decreased respirations and that hypoventilation, these clients are going to show some neurological manifestations of that buildup of CO2, so that high CO2 level in the blood and that low oxygen or hypoxia. So think about things that result from not enough oxygen to the brain. This can be things like confusion, lethargy, drowsiness, irritability, and headache. As this progresses, it can progress all the way into late signs like seizures and even the potential to progress to a coma. So some pretty serious things here. On the flip side, our clinical signs to go to respiratory alkalosis. What is this going to look like in these clients? So in respiratory alkalosis, remember we have that low CO2, so we don't have enough acid, and we have that fast respiratory rate, so we're hyperventilating here. This can cause things like lightheadedness, dizziness, confusion. We can see tachycardia, and due to the other process that's happening in the background that's causing this, our client can also see hypocalcemia. We know hypocalcemia causes our textbook signs like that numbness, tingling, especially around the hands and the mouth. And the same with respiratory acidosis. The late findings here in respiratory alkalosis, it can even progress to seizures and coma. So it's so important to identify these findings early and intervene so it doesn't escalate to seizures or coma, which again are so dangerous. Alrighty, so now again, let's get into the nitty-gritty. Let's talk about the compensation. I think this is the trickiest part to get, but once you understand it, you see how it all fits together, and it's gonna make a lot more sense. So how do we compensate on a respiratory side? So just how in metabolic acidosis and alkalosis, our lungs stepped in to compensate for our kidneys, it's the reverse here. Now we're in respiratory acidosis and respiratory alkalosis, so our kidneys are gonna jump in, help out their friend, the lungs, and we're going to compensate via the kidneys. Alrighty. So respiratory acidosis, we know already we have too much acid from the buildup of that CO2. So our kidneys, how are they going to help? How are they going to help out their friends, the lungs? They're going to jump in and secrete hydrogen in the urine, which we know hydrogen is an acid, it's acidic. So by excreting it and getting it off, we're going to raise our pH, get less acid, which is going to bring us back up, hopefully into a normal range, but we're going to trend higher. And also our kidneys are going to help to reabsorb or send back that bicarb into our blood or our bloodstream. We know that bicarb is a base, so this also helps to raise our pH. Now on the flip side, in respiratory alkalosis, we know we have those low levels of CO2, which is an acid, which is why we're alkalotic. So what we need to do is increase the amount of our acid in our system to be able to lower our pH out of alkalosis. So what our kidneys do to help is they reabsorb hydrogen and send hydrogen back into the blood because it's acidic. When we have that more acid in our blood, it brings down the pH out of alkalosis. We also are going to reduce the amount of bicarb we're producing, which is base, and these together, paired together, are going to help to bring our pH back down to a normal level. Again, we're aiming for that 7.35 to 7.45. Alrighty, so quick knowledge check. Make sure you guys are sticking with me. I know this is difficult stuff. So will hydrogen concentration go up or down in respiratory alkalosis? So essentially, will it increase or decrease? So as a compensation for respiratory alkalosis, will the body compensate by increasing or decreasing our hydrogen concentration? So think about respiratory alkalosis. We're alkalotic, we have too much base and not enough acid. We know that hydrogen is acidic. So to compensate, will the body compensate for being alkalotic by increasing acid or decreasing acid? That was tricky, and I think a lot of it's also in how I phrased it, so I didn't mean to confuse anyone, but essentially when the body is in a state of respiratory alkalosis, I asked you guys about compensating. How are we compensated here? The body compensates by trying to increase our hydrogen because hydrogen is acidic, which will offset the alkalosis. So increase was our correct answer, but that was a tricky one. So let's hop to our nursing interventions, which I think really help to kind of drive home what's going on in the body. So remember that this state of alkalosis or acidosis is never the primary diagnosis, but rather it's the symptoms or the pitfalls of another condition. So obviously, first and foremost, we need to treat the underlying cause. But there are some essential practices that we always need to be aware of as nurses. We want to make sure we're monitoring our ABGs so we can know if we're trending in the right direction. We need to give IV fluids and replace electrolytes as needed. For respiratory acidosis in particular, we need to work on improving our airway and our breathing because again, these clients are hypoventilating. So we can do this by supportive measures. We're going to raise the head of the bed. We're going to suction if the client has any secretions. We can apply supplemental oxygen, maybe through a nasal cannula, maybe something more. And we can also give medications to treat that underlying condition. So we said there can be chemical respiratory depression, maybe from something like opioid misuse. We can give a Narcan to treat for this. If this respiratory depression results from magnesium toxicity, we can give the antidote of calcium gluconate to help with this. Unfortunately, if that hypoventilation does progress and we're not able to fix it with chemical interventions, we do need to be ready to intubate the client if that is needed. Alkalosis. So respiratory alkalosis, we need to work also on improving our airway and our breathing, but in a different way than respiratory acidosis because in alkalosis, we are hyperventilating. Remember, causes here can be like anxiety attacks, pain, fever can even cause this. So we may need to apply that supplemental oxygen and we may need to give medication. So if we're having an anxiety attack or a panic attack, a common medication we would give would be like a benzodiazepine or like a lorazepam. And we also want to encourage slow, deep breathing, calming them down, decreasing that rate of ventilation, and maintaining a calm atmosphere. Decreasing stimuli may also help with this. Alrighty, so we're going to hop back to that flow chart. Again, this is kind of a great home base for us to tie it all together. So in summary, to summarize the respiratory side of things, just like we did with the metabolic side of things, in respiratory acidosis, we have a low pH. This happens from hypoventilating and holding on to too much of that acidic CO2 because we're not blowing enough off. Our kidneys compensate, but kidneys compensate very slower. When the lungs compensate, they're a lot quicker. Our kidneys are more of a delayed response. So our kidneys are going to do their best, but they're going to increase elimination of hydrogen to help raise the pH of our blood and get rid of some of that acid to take us out of acidosis. They're also going to hold on and retain that bicarb to hold on to more base and thus help raise our pH. But again, this happens pretty slowly. The kidneys work a little bit slower than our lungs do. So this client may need additional support like airway and breathing support, and we may even need to push some IV bicarb just to help out a little bit in the meantime. All right, on the flip side, let's switch to respiratory alkalosis. So here we know we have a high pH, here we are hyperventilating, and we have low CO2. So we're breathing too fast, we're breathing off all of that acidic CO2, putting us into a state of respiratory alkalosis. So again, the kidneys compensate. They're trying to do us a solid, but they do it pretty slowly. So it's going to be delayed. Our kidneys are going to hold on to hydrogen in the urine, which we know is an acid. They hold on to this acid, which brings down our pH, takes us out of alkalosis. they're also going to lower their bicarb production, and these two things together will work to lower our pH. But again, it's happening pretty slowly. The kidneys, I guess, live on island time, so we need to make sure we're providing supportive measures like encouraging the client to breathe slower if they're hyperventilating, giving a medication to treat a panic attack or an anxiety attack that could be triggering this, or if this client is on mechanical ventilation, we need to go look at that ventilator and maybe decrease the ventilator settings. This may be ventilator-induced respiratory alkalosis. Alrighty, so that sums up the bulk of our lecture content. We talked all about the respiratory side, the metabolic side. Now let's go ahead and talk about how we can be presented with a set of lab values. How are we expected to tell these apart? Alrighty, so let's pull up our Rome table, or our Rome slide. So we're not talking about the city in Italy, unfortunately, but we're talking about our trick to be able to differentiate these states of metabolic or respiratory acidosis and alkalosis. So there's a lot of different ways to do this. I know a lot of schools teach different things. Honestly, my best advice to you is to look a little bit into all the different ways to do this and pick the one that works best for you. This is the one that I particularly like, but you may be different. All right, and again, a great time to take a screenshot or take this one with you. But ROME stands for respiratory opposite, metabolic equal. So what this means is we know we can decipher if it's acidosis or alkalosis. That one's pretty easy. We just take a look at that pH. Is it between 7.35 and 7.45? Then we know it's normal. If it's higher than 7.45, we know we're in alkalosis. And if it's lower than 7.35, we know we're in acidosis. So there off the bat, we've at least checked off one thing. Next, we need to be able to figure out, is this respiratory or is it metabolic? And the way we do this is by using the ROME trick. So respiratory opposite means our pH and our carbon dioxide are going to trend in different directions. So we know it's respiratory if, for instance, our pH goes up, it means carbon dioxide will go down, and vice versa. If pH is going down, our carbon dioxide will be going up. Respiratory works opposite. Metabolic works equal. So this case, it involves our pH as well as our bicarb. So if our pH is increasing, we're going to go the same direction with our bicarb. Bicarb will also increase. If our pH is decreasing, our bicarb will decrease. So respiratory opposite, metabolic equal. The last point to drive home, we figured out if it's acidosis or alkalosis, we figured out if it's metabolic or respiratory. How do we know if the body has finished compensating or if it's still trying to compensate? This is where uncompensated and compensated part comes in. So if the pH is still abnormal, we know it's uncompensated because the body has not been able to return to a normal range. Whereas if we have a compensated version, it means our pH has been able to return to a normal pH level. In uncompensated, because we're still abnormal, we may have a normal carbon dioxide or bicarb, whereas in compensated, the body has worked to compensate to get that pH back into a normal range, and because of this, our carbon dioxide or bicarb may still be a little bit out of whack. That's just part of the compensatory mechanism. Alrighty, so we know our trick. Screenshot this, write this down, take it with you, and we're going to use it to answer our 3 questions today. So let's go ahead and jump to question number 1. Alrighty, and another reminder, we are going to give you guys the lab results. The NCLEX gives you normal reference ranges. Okay, so read through this. I'm going to give you a few seconds to go ahead and think it over in your brain, put to use what we've worked today, use it as a lens, and we'll go through this one together. These are tricky and intimidating at the beginning, but I think once you get the hang of it, they're actually kind of fun. They're like a puzzle. All right, I see lots of answers coming in. Great job, you guys. We have some smart cookies in the bunch. Alrighty, so in this case, let's look at our values. The first and easiest place to start with is just that pH. So we know normal 7.35 to 7.45. We're at 7.28. So is that high or is that low? That's going to be low, which means this is a state of acidosis. Okay, part 1 of 3, check, we're done, correct. The next part, is it respiratory or is it metabolic? So what we would look at here is our carbon dioxide and our bicarb levels. So we know our pH is going down. Our CO2, supposed to be 35 to 45, is 55. So this means it's high. So our CO2 is increasing. What about that bicarb? Bicarb is 23, which is within the 21 to 28 normal range. okay, we're not worried about that one. But if our pH is going down, but our carbon dioxide is increasing, remember it's respiratory opposite. These are trending in opposite directions, therefore we know it's respiratory. So far we have respiratory acidosis. Now I'm going to add one more thing to this. Is this compensated or is it uncompensated? Well, in this case, we still have the pH is 7.28. So is that back within our normal range of 7.35 to 7.45? No, it's not. Therefore, it's not been fully compensated. So we would call it uncompensated respiratory acidosis. But I don't think that asked you if it was compensated or uncompensated or not. I think it just asked you for respiratory acidosis. So option 3 was also our correct option. But most of you guys got that right. So way to go, you guys. All righty. Question number 2. I'll give you guys some time to do this on your own. Let us know what you think, and we'll walk through it at the end as well. But the first one was warm up, even though you all did so well. And now let's see if you guys can get this. So remember, we start with our pH, figure out if it's acidotic or alkalotic. We move on to Rome, is it respiratory or metabolic? And then let's figure out if it's compensated or uncompensated. Whew. This is a long live, so thank you so much for hanging in there with me. All right, so I see lots of answers coming in. Let me check the chats. Okay. And I see most of you think it's respiratory, but it looks like we have a little bit of different answers on whether it's alkalosis or acidosis. All righty, so let's go through it. We're starting with our pH per usual. So 7.48, that's out of range, just slightly. Is it high or low? That's gonna be high, bless you, which means it's alkalosis. So if we're alkalotic, okay, step 1 of 3, check. Give yourself a pat on the back. We know we have that. So we're in a state of alkalosis because our pH is high. Now let's move on to that bicarb and that carbon dioxide. So our carbon dioxide is 30. This is a little on the low side. Normal range is 35 to 45. So our carbon dioxide is going down. What about that bicarb? We have bicarb as 24. This is normal within range. And so in this case, if we, again, respiratory is opposite, metabolic is equal, our pH is going up, but our carbon dioxide is going down, that's opposite, meaning we know it's respiratory. Okay, step 2 of 3 complete. Now we know it's option 4 at this point. That was our correct option. But is it compensated or is it uncompensated? So first thing to look at, is that pH back within normal range? No, it's not. It's 7.48. It's still high, but our bicarb is normal. So we know this is uncompensated respiratory alkalosis. Way to go, you guys. All right, question number 3. I'm going to let you guys loose on that one. Do it on your own. I know you can do it. I prepared you well. Drop those answers in the chat. Remember, start with pH, then we go to Rome, is it respiratory or metabolic, and then we see if it is compensated or uncompensated. Alrighty, I'll give you a few more seconds. Again, do your Rome trick, draw your arrows, do your decimals, however it works for you. I know there's a lot of different ways that we can do ABGs. The trick is just finding the way that works best for you. All right, I see a couple of answers coming in. Oh, I see some good ones. Way to go, you guys. Proud of you. All right, so let's walk through this one. First things first, what's the pH? It's 7.37. Now that's normal. It's between 7.35 and 7.45. So hey, normally we figure out pH first, but we know it's compensated. In this case, it's normal, but it's still on the low end of normal. So keep that in mind. If you want to draw a little down arrow in parentheses, that may help you out. Now let's look at our carbon dioxide and our bicarb. So these are both low. Carbon dioxide is 33, normal range is 35 to 45, and our bicarb is 20, our normal range starts at 21. So they're both slightly low. In this case, remember our Rome trick, our pH, even though it's still within normal range, is on the low side. So we can give that a down arrow, so to speak. Now respiratory is opposite, but carbon dioxide is also down. So we know it's not respiratory, but our bicarb is low as well. So metabolic equal, they're both trending downwards. In this case, we know it is metabolic. So we know it's metabolic acidosis, and because our pH has been compensated for, therefore it's returned to a normal range, it's compensated metabolic acidosis, which would be option number 1. So way to go, you guys. You did so well today. Reminder, we're back on Wednesday and Thursday with question drills. Wednesday is an infection question drill. Thursday, we're going to be covering developmental milestones. Let's hop to a quick little QBank slide. Again, here's a look into our UWorld product. For anyone that has already purchased or is thinking about purchasing, this is our QBank, so you can get a little look at it now. These are the subjects and the systems that you should select in order to get more questions that include those like acid-base imbalances and ABGs, so you can test out some of your knowledge that you learned today. So challenge yourself, get a little more practice in. This QBank slide is just telling you exactly how to do that. Thank you so much for joining. It was so great to have you all here. Join us again tomorrow on all of our social channels at 11 a.m. and 3 p.m. Central Standard Time for question drills with Nurse Jackie. We're also next week going to be at NSNA, so if anyone's going to be at NSNA in Seattle, stop by our booth and say hi. We are so excited to be there. With that being said, have a great rest of your day. Bye now.